Good day, dearest great surgeon. Missed you all a lot, and let's continue our orthopedic chapter together. Together we can. As we all know that orthopedics is one of the main pillar of MRCS exam, and it depends on the preoperative, postoperative, as well as the trauma and anatomy chapters. So it's overlapping with all of them as well as the pediatric chapter. So it's important pillar in the exam. Take care and let's go through this chapter and crack it together. Together we can. During your study for orthopedics, you have to be aware of the fracture management because there is no orthopedics without a fracture. And as the old men say about the orthopedics, I have a fracture, I need to fix it. So, bony injury resulting in a fracture may arise from trauma or even stress, as we mentioned from the stress fracture before, or even pathological due to abnormal bone which fractured during normal use of following minimal trauma due to presence of tumor or bone disease or systemic disease. The diagnosis involves not just evaluating the fracture itself, because a predisposing factor must be resolved, such as the site and type of injury, but also other associated injury and distal neurovascular deficit accompanying this fracture. And this may elaborate not just the clinical examination, but a radiograph may proximal of distal joint is essential to evaluate the joint. So, if you have a fracture, for example, in a tibia, you have to do an ankle and a knee x-ray, the above and below the fracture. And by the way, when assessing an x-ray, it's important to assess the change in the length of the bone and the angulation of the distal bone, as well as the rotational effect. Those will be a pillar in your decision making regarding this bone fixation. And the presence of foreign body is critical to be recognized, even if it was a glass. It's good to know the pattern of the fracture when it's oblique, when the fracture lies obliquely to the long axis of the bone, or comminuted where we have more than two fragments. And the comminuted fracture reminds me of the flail chest, by the way, more than two reps, more than two fractures in more than two reps. This is the flail rep in the comminuted fracture for the bone. The rep is a bone, by the way. So a segmental fracture when we have more than one fracture along one bone, or a transverse fracture which is perpendicular to the long axis of the bone, or even spiral fracture where there is a severe oblique fracture with rotational long axis of the bone. All of those patterns are asked in the exam, and will ask you the pathological fracture, what pattern of fracture it will cause. It might be oblique, it might be transverse, so take care. It's not only the cause, it's the pattern of the trauma that might affect the pattern of the fracture. And to assess what is the definitive management for a fracture after finishing your first aid for the patient, and by the way, the first to do is not the definitive management. Take care. Immobilization is the first to do for any fracture. Debridement is the first thing to do for any open fracture. Resuscitation of the patient is the first to do before dealing with the fracture. Take care. We are dealing with a patient, not with a fracture. Don't do like the orthopedics. The orthopedic patient, the orthopedic doctor say, I have a fracture, I need to fix it. I will be quick, I will do it fast. It's not about being fast, it's not dealing with a fracture. The human being is not only a bone. Deal with the patient. The best management for any fracture, especially the closed fracture, is open reduction, internal fixation. This can't be achieved except for a clean fracture. But if we have an open fracture, we will have to use Gastelo and Anderson classification system. It has 3 grades, 1, 2, and 3, and type 3 in Gastelo has 3 subtypes. Grade 1, when we have a low energy trauma caused a wound which is less than 1 centimeter. This is great. But in grade 2, we have it greater than 1 centimeter, but take care, there is a moderate soft tissue damage. But in type 3, the wound is more than 1 centimeter, but extensive soft tissue damage. It will definitely need coverage. So, The cut-off number in Gastelo classification, we are talking about 1 centimeter. Remember when we are talking about the coverage with local flap or a graft and said our cutoff will be 1 centimeter, above 1 centimeter. Let's think it can be done with primary suturing, or it requires grafting, or even local flap. Now in Gastelo open fracture classification, we are talking about this concept. In type 1 Gastelo, it will be less than 1 centimeter, low energy wound. In type 2, it will require a great energy, and it's about 1 centimeter wound with moderate soft tissue damage. In type 3, it was a high energy wound, more than 1 centimeter, requires extensive soft tissue damage and extensive coverage. Regarding the three subtypes of type 3 in Gastelo classification, take care. In type 3A, we have an adequate soft tissue coverage already. In type 3B, we have inadequate soft tissue coverage already. But in type 3C, in type C, arterial injury occurred, and this is an emergency. We have to deal with the vascular before the bone. To the key point to manage any fracture: immobilization of the fracture, including the proximal and distal joints, careful monitoring and documentation of neurovascular status, particularly following the reduction and immobilization. Manage infection, including tetanus prophylaxis. IV broad-spectrum antibiotic for open injuries is a must. As a general principle, all open fracture should be thoroughly debridement. Debridement is the first to do. After the first to do we talked about from the key points, and internal fixation devices avoided or used with extreme caution. So there is no internal fixation for open fracture. It's always external fixation. External fixation by external laser off or even external fixators, whatever, but there is no plate and screw where we have an open fracture, or will you screw the patient himself. Open fracture an emergency and should be debrided and lavaged within 6 hours of the injury. By the way, the crushed injury for the limb, crush injury for the limb for more than 6 hours might require amputation to prevent the reperfusion injury of this limb, and necrosis and myoglobinemia and myoglobinuria. This will occur and cause a renal failure and systemic organ failure. We are dealing with the patient life, not only the limb. Might be the only way to save this patient life is to amputate his limb. So open fracture is a big deal, and even a closed fracture might be causing a compartmental syndrome and require fasciotomy. This is a big deal. Take care. So let's apply our knowledge regarding an open fracture. We will do ABC and respect it. Give the patient analgesia, immobilization, neurovascular should be assisted, imaging of the patient above and below the fracture, antibiotic and antitetanus will be given, debridement with general lavage before 6 hours, giving the patient external fixation, assessing for coverage later on. This is open fracture simply. And if it's closed fracture, assess for compartmental syndrome. By the way, compartmental syndrome is very critical and must be suspected. By the way, the open fracture or closed fracture both can lead to a pulseless limb. When you don't feel the pulsation in the fractured limb, please reduce the fracture and immobilize it and splint it and reassess after reduction of the patient fracture. After reduction, the compromisation of neurovascular bundle might be transient and the patient regains his pulse again. Otherwise, it must be explored immediately after resuscitation of the patient. Save the whole patient, not only the limb. And regarding the fracture, it might be tricky sometimes with some bones that they are at the time of the incident, it might be not apparently fractured, like the scaphoid bone. So, in the scaphoid bone, when a patient falls on outstretched hand in the exam, he won't tell you that he has hit his scaphoid bone because he knows that you know this idea. He will tell you that on examination there is a tenderness of anatomical snuff box. However, the forearm and hand x-ray are normal. What is this? Of course, this might be a scaphoid fracture. So always discharge this patient home with a futura splint and the fracture clinic appointment is given after 2 weeks to reassess the patient. This could be a scaphoid fracture and should be temporarily immobilized pending further review. A futura splint will immobilize better than an arm sling for this problem. Take care. And by the way, the scaphoid bone might be liable for bone necrosis. So, ischemic necrosis for a bone is a serious issue and can occur with the scaphoid bone fracture if not recognized. That's why immobilization is very important to help this bone heal because it takes its blood supply from the radial artery from the distal end. Dear great surgeon, take care. The thumb spica or the futura splint with thumb spica is indicated as the injuries of the scaphoid, leonate, thumb, or even the first metacarpal bone. Even in the gambic thumb or decurvian tenosynovitis, it's indicated. It's formed from just distal to the interphalangeal joint to the thumb to the mid forearm, and application is done by cutting a hole in a stockinette for the thumb and the forearm in a neutral position with the thumb is a wing glass position. So in the wine glass position, this will be the thumb spica with the futura splint. A very great important question might come up to your mind. It's not stupid at all to think if the nails and the screws are permanent or temporary. By the way, nowadays there are a temporary absorbable nails and screws, yes, but most of the surgeons can put them permanently. If there is no infection and there is no problem, they can be put and be safe lifelong. That's why we choose the nails and the screws and the plates inert from inert materials that doesn't react with the body. So by the way, if the patient is irritated from the plates and the screws, it can be later on removed after 6 months or 1 year even, but not before this. Practically speaking from real life. By the way, if a patient have done an internal fixation with a plate and screws from 1 year ago and came to you with an infection and pus coming out of this site of fracture, what would you do? Of course, you have to make sure that the patient as a whole didn't take the course of being in a sepsis or even a septic shock. Take care from this. It's very important. So, there is no sepsis for the patient. Deal with the local wound. Let's see the local wound. We have a foreign body here, which is the plate and the screw. So we have to remove the plate and the screw from this fracture. After removing the plate and the screw, deal with the whole thing and go for generous lavage. And now we can talk about the definitive management. If there is a fracture still exists, so this fracture had been managed incorrectly and was neglected for a long time. If there is a fracture, remove the blade and screws. You can do then an external fixator to keep the fracture inside, but there is no internal fixation wherever there is infection because no one wants to build a house of steel for the bacteria. And of course, all of this under resuscitation and umbrella of antibiotics. Dear great surgeons, take care. Scapular fracture are uncommon, but they are usually caused by a direct trauma or due to RTA, road traffic accidents. The patient will present you with dropping of the affected shoulder with apparent lengthening of the arm, particularly with a fractured neck of the scapula. Most can be treated conservatively, by the way. Internal fixation is indicated for some articular fracture of the glenoid cavity. So take care and keep in mind the scapular fracture and don't confuse it with the dislocation. Take care, scapular fracture will be apparently lengthening of the arm. With the fractured neck of the scapula, there will be a dropping and affecting the same shoulder of the site of the trauma. Don't confuse the anterior dislocation of the shoulder, which is the most common type of shoulder dislocation, because it will be presenting with a swelling in the deltoapical groove with undue prominence of the acromion process. In addition, there is a flattening and loss of contour of the shoulder just below the acromion process. and lowering of the anterior axillary fold. By the way, if the axillary nerve is damaged, the patient will be presenting with loss of the sensation over the upper and outer aspect of the arm. By the way, keep in mind always the pathological fracture. The pathological fracture might occur from electrolyte disorder or generalized weakness or even osteomalacia or mineral deficiency or even bone metastasis or bone cancer. The most common bone cancer in general will be the bone metastasis, and the most common primary bone tumor is the osteosarcoma. So keep in mind the most primary bone cancer, osteosarcoma. By the way, most of the bone metastases are osteolytic except for the prostate cancer metastasis is osteosclerotic. But this doesn't mean it doesn't occur with a fracture. It can cause even a fracture. Take care. The most famous sources for the bone metastasis is the breast, thyroid, and prostate. And again, prostate is the most osteosclerotic cause. These great surgeons take care. Osteosarcoma is the most common primary bone tumor. Again, osteosarcoma is the most common primary bone cancer, while multiple myeloma is a plasma cell myeloma and simply myeloma. It's a cancer of the plasma cell, a type of white blood cell that normally produce antibody even no symptoms are noticed initially. Take care. Multiple myeloma is not the most common bone tumor. It's a plasma cell cancer. Multiple myeloma affecting the bone doesn't mean that it is a primary bone cancer. It's a plasma cell cancer. Now let's take a glimpse over a developmental bone disorders because they are frequently asked in the exam. Take care. The developmental disorder of the bone, like the Rickets, Osteogenesis Imperfecta, are frequently asked in the exam. So let's take a glimpse over the Rickets. The Rickets is a childhood form of the Osteomalacia. So Osteomalacia for adult, Rickets for pediatrics. That's why pediatrics and orthopedics overlap. It's due to the failure of the osteoid to ossify due to vitamin D deficiency. And by the way, in the exam, he might tell you the features of rickets, not mentioning the rickets itself or even mentioning any vitamin D. He will tell you that the boy might be have posing of the forehead, have bowing of the knees. Take care from those ideas that give you a hint this is a ricket. The rickets symptoms start about the age of 1 year old. The child is small for age and there is a history of failure to thrive. Bony deformities include bowing of the femur and tibia, a large bead, deformity of the chest, and the chest wall with thickening of the osteochondral junctions, which will cause ricketary rosary beads in the chest, and the transverse sulcus of the chest caused by the pull of the diaphragm, which is the Harrison sulcus. So it will cause a rosary bead and Harrison sulcus. Even the X-ray will show a widening and cupping of the epiphysis of long bones. Most will be apparent in the wrist. So take care and keep in mind the rickets. This all can be managed with vitamin D. By the way, the pediatricians now advise to start vitamin D from day 0. From the very first day of the childbirth, we give vitamin D right now. Dear great surgeon, take care. Osteoporosis is not the same as osteomalacia, and it's very common recall in the exam. Osteomalacia is due to a lack of vitamin D. It's the adult form of the rickets, while osteoporosis is a decrease in the bone mass, while osteomalacia is lacking of calcification. Osteoporosis have many precipitating multiple factors. Osteomalacia is lacking of the calcification. Mal. Mal means deficiency, so never forget it. Osteomalacia means deficient. You will find in the exam he will telling you that the calcium level is low, is low, is low. Calcium low, phosphate low, parathyroid is high or normal, alkaline phosphatase is high, and there is a fracture. What is this? This is osteomalacia, because in osteoporosis there will be a fracture and there is a decrease in the bone mass and lacking calcium and estrogen. But take care, The labs will be showing that the electrolytes are normal. You will find that the calcium, the phosphate, parathyroid, and everything is normal. This is the osteoporosis, where you lose your bone mass. While osteomalacia, there is a lack of calcification and lack of vitamin D. Yes, I know that the osteoporosis is linked to postmenopausal and hormonal changes in the female. And this is the trick in the exam. Is it osteomalacia or osteoporosis? Most probably, the osteoporosis will be having a normal electrolyte and normal calcium level, normal phosphate. This is the trick. While osteomalacia, remember, mal, it's a loser zone where you find all your electrolyte blood sampling are low calcium, low phosphate. Keep those in mind. Dear great surgeon, take care that osteoporosis is the reduction of the bone mineral density, loss of the density. It's not an osteopetrosis. Osteopetrosis is an autosomal recessive condition, commonest in young adults. The patient will be mostly 15-year-old boy presenting out as a patient with tiredness, recurrent throat chest infection, gradual loss of vision with multiple x-rays showing a parietal bone. This is your key, a parietal bone. He will accompany you with a long history, but your key will be the x-ray showing a parietal bone with no differentiation between the cortex and the medulla. It's like a marble. So osteopetrosis is an autosomal recessive condition, commonest in young adult, present with symptoms of anemia thrombocytopenia due to decreased marrow space in the bone, and the radiology will be revealing lack of differentiation between cortex and medulla. A normal X-ray, you can see the rim of the outer cortex and the inner medulla showing the haversial system like. But in the osteopetrosis patient, there is no differentiation. He has a marble bone. And it's not good to have a marble in your bone. You have to have a cortex and medulla, which is not true for the osteopetrosis. So don't confuse between osteopetrosis and osteoporosis. Osteoporosis, you will find it in a postmenopausal with no change in the electrolyte of the blood. While in the osteopetrosis, it will be a young patient autosomal recessive condition with anemia thrombocytopenia and will tell you that the X-ray with parietal bone or even marble. Keep this in mind. Another important topic in pediatric orthopedic is the osteogenesis imperfecta. It's caused by defective osteoid formation due to congenital inability to produce adequate intracellular substance like osteoid, collagen, and dentin. There is a failure of maturation of the collagen in the all connective tissue, and the radiology may show translucent bone. Multiple fracture, particularly of the long bone and wormian bones with irregular patches of ossifications and trifoil pelvis. This is the fracture type of the osteogenesis imperfecta. So we have a marble bone with the osteopetrosis and we have a translucent bone like glass appearance of the osteogenesis imperfecta. In osteogenesis imperfecta, why I told you it's like a glass? Because it's translucent and liable for fractures. So again, osteogenesis imperfecta, it's a defective osteoid formation due to congenital inability to produce adequate intracellular substance like the osteoid, collagen, and dentin. The whole subtypes of the osteogenesis imperfecta are according to the collagen poor and insufficiency. The failure of maturation of the collagen in all connective tissue is the key to diagnose your osteogenesis imperfecta, and the X-ray finding are your key to make sure of your diagnosis. So translucent bone, osteogenesis imperfecta. Marble bone, we are talking about osteopetrosis. Bowing of the bone, is it adult or a child? A child, it's rickets. In an adult, so think about it as osteomalacia. Why it's not osteoporosis? Osteoporosis, you will find all your chemical labs of the electrolytes are normal. Someone asked me, why there is irregular patches of ossification in osteogenesis imperfecta? Because he have recurrent fractures. There will be a trifoid pelvis. You will find this patient translucent bone, multiple fracture, particularly of the long bones, with more median bones which are irregular patches of ossification due to multiple fractures. He has a glass bone which is liable for fracture. Keep this in mind. So always thank God that osteopetrosis is a bone recessive disease where you have to have a mother and a father with lucky enough to have osteopetrosis with a lucky love story to love each other after a long love story, and the day of the groom and the day of the wedding they tell each other I have osteopetrosis. Now this is the lucky child to be having recessive father of osteopetrosis and recessive mother of osteopetrosis to give him this gene. It's a very tough, full of broken bone osteopetrosis. So don't marry a one with osteopetrosis unless you are not osteoporotic patient. Unless the osteoporotic groom and wife are planning to have a marble one child for their life. Hope you enjoyed today's lecture. Until we meet again, have a good day. Yours, Dr. Bishoy. Together we can, with the grace of God.